Brantley Thrasher. I'm the chair of the department at the University of Kansas Medical Center, and most of what I do is prostate cancer work.
You've long had an interest in educating the primary care community about prostate cancer and building relationships between primary care doctors and urologists to provide well-rounded information for patients. Can you tell us how that has been evolving over the past few years?
You know, I think things have changed so much. We have the primary care physicians now that are supposed to be our entrance to the portal of care. We see a lot of the primary care physicians that know a great deal about prostate problems, men's health problems. We also have a group that don't, and we try to spend a lot of time speaking with our primary care colleagues, working with most of our patients to try to create a team approach, co-managing the patients. So now I am in a unique position in that I'm in an academic medical center. It may be different from some of the urologists that are in a private practice group, a large practice group, a multi-specialty group. In my case, the people that I know in the academic medical center, I can converse with on a quite frequent basis. But those that are from western Kansas, southern portion of Nebraska, we have to spend a lot of time on the phone talking about co-managing these patients. When to do PSAs, when to do follow-ups. I mean, quite frequently I receive patients from out of town. I might do an operation on those patients. They ask the question, what do I do about follow-up? Because I don't want to come all the way back down here. I spend some time getting on the phone, speaking with the primary care physician and saying, we need to co-manage, and this is what I would recommend. What are your thoughts? And I think it's very important that as long as I put, as I tell my residents and other staff members, if I put the patient first, and I think what's most convenient for the patient, and I keep that as the primary cornerstone for every decision that we make. When I speak with the other physicians, we want to make sure that it's convenient, and we want to make sure that the primary care physician feels very comfortable with that follow-up. If they don't, then I need to make sure that I'm either speaking with them or I'm taking it on myself to say I'll follow the patient up right where I am. But most of the time it's the other way around. Most of the time they're very comfortable doing just that.
Are you getting a lot of questions today from patients and from their primary care physicians regarding newer forms of treatment?
Absolutely. In fact, I had a recent man that came in. He was in his 50s. He's a businessman, done a lot of reading. He had already looked on the internet and found out some information about the Canadian group and their active surveillance protocol. Wanted to look into it further. In fact, his primary care physician had said, this is something you might want to consider since you have a low volume Gleason 6 cancer, PSA is well below 10, and there's nothing on digital rectal examination, makes you a perfect candidate. I spent well over an hour speaking with that man saying, now, agreed, active surveillance might be a possibility. Remember, right now, as we look at the data that's out there, it's very short term. We really don't know some of the PSA triggers. We don't know a lot of issues now that would help me, in my mind, say this is a standard of care now. It's still evolving. And we had a long conversation about that. But following that, I wrote a very detailed letter to the primary care physician and even got on the phone, and we had a discussion about active surveillance and where it stands. And I think there was a lot of information that went back and forth on that. I think he felt very comfortable getting off the phone, that he knew a lot more about active surveillance, and I knew a lot more about his thought process mentioning it to the patient.
Given the complexity of decision processes for prostate cancer patients today, what are the 3 most important things you try to communicate to a newly diagnosed man?
You know, I try to make sure that they're going to a reputable website. And the first thing that you're going to say is, why do you say website? Because most of my patients coming in now are well-informed consumers. They are. They may come in with 80 pages off the internet of a brand new chemopreventative agent. Don't you know about this mushroom extract? Well, no, sir, I don't, but you're getting ready to educate me. And so what I try to do is make sure they do have a reputable website to go on to look up information. What is the latest and greatest? That's one thing. The second thing that I tell patients is this: I always recommend a second or third opinion. I tell them this: you're going to be, after treatment, married to that physician for quite a long period of time, especially with prostate cancer. Slow-growing cancer, there are many adjuvant therapies. You may have a long interval of treatment, and you need to be very, very comfortable with that person, but you want to get a second, third, fourth opinion sometimes. I mean, I do believe that you have time to do that, number one. Number two, it's critically important that you understand that most of the things that we do, once you cross that bridge, you don't back up. If you buy a car, you get a lemon, you trade that in, you lost a little money rolling it off the parking lot, but it's not the same with prostate cancer. If you take the prostate out, we don't do a do-over. You do radiation therapy, you don't do a do-over. They're going to give you a maximum amount, you won't get more to the pelvis. So I think it's critically important they're comfortable with the treatment decision and they've done their homework. The third thing that I try to make sure they understand is there is a lot of information out there right now on the internet that may or may not be true. It's not policed. They need to understand that a physician may tell them something on a particular treatment that I would disagree with, but I try to lead them to not only a credible source but also credible literature. Okay, I want them to feel comfortable that the treatment that they're heading toward, whether it might be surgical, radiation therapy, even cryotherapy, that they really understand the ins and outs of that. And I spend a lot of time doing it. In fact, a new patient for me is going to probably be an hour of counseling, sometimes more than that.
Is there anything else you'd like to touch on?
This whole business of our evolving healthcare, and especially when it pertains to men's health, is so complex now. And although we do have informed consumers, we also have a lot of information out there that may or may not be true. I always recommend to the patients that rather than bombard themselves with a multitude of potential treatment options, potential chemotherapeutic options, supplements, micronutrients, make sure that they know that that what they're getting is real and not Memorex. And I think one of the best ways to do that, the AUA has a fantastic website. AUAnet.org will take them into some patient portals where they can learn more about it. We have websites that are very credible that I think talk about treatment options and complications, etc. And we have guidelines that patients can actually go on, and those are based on evidence. And that's really what we want to push. But other than that, I think that the complexities of healthcare now and the primary care doc and what they're doing and what we're doing, as long as we're operating in a team approach, trying to do what's best for the patient, that's the key.